This conference will now be recorded. This conference will now be recorded.
Yes. Tina, does this work for you? Okay. Cool, guys. So we're going to start getting into some of like the actual nitty-gritty stuff that's actually going to be pretty applicable to you and pretty cool, because now you can really start to treat people and make a difference with this. Does anyone know what the difference between somebody that's good-ish and somebody that's great?
Knowledge and skills.
It is knowledge and skills, but there's a couple things that are specific about that, and that's knowledge and pathophysiology, especially at the EMT level, right? The truth is this: you can teach a monkey how to put on a pelvic binder and a tourniquet, but if they don't understand what's happening with the body and why we're doing it, it's kind of, I don't know, I'm not saying it's useless, right? But if you ever decide you want to compound and get smarter and go further, you have to have a good in-depth knowledge and understand why we do things, and shock is part of that. So we're going to review some anatomy, physiology, the circulatory system, signs and symptoms of shock. We're going to learn how to control bleeding tonight. We're really going to take the time to go over shock and the different shock states. Okay. You guys, I'm sure Becca covered this in depth when we first started. Okay. What is the job of the heart?
Pump blood.
Okay, good. But what is that like? What does that actually mean?
What other blood perfuse technique it does gas?
To get, oxygenated blood.
Yeah, right. This is your pump. This is going to get everything where it needs to go. So when this starts to fail, what happens? Right. We have a backup, and that leads to a state of shock. It does, right? It's more specifically cardiogenic shock. Okay, who can tell me the difference between arteries, veins, and capillaries?
Arteries carry oxygenated blood away from the heart. Capillaries are microscopic blood vessels, and then veins are
Deoxygenated blood.
Is there ever an exception to the rule with arteries and veins?
Yeah.
Going from the heart to the lung.
Good, good. So we understand that the pulmonary artery switches. Okay.
Mhm.
Good.
Pulmonary vein.
Okay. I know Mr. Hoover covered the hematology lecture last week. Who can tell me what the primary function of blood is? Okay. What else can blood do? Or what else does blood do? Clots. Okay.
protection.
Transport of gases, nutrients, excretion, protection, regulation, and then clotting is also a big thing that blood does when we have an injury. So perfusion and hypoperfusion. Can someone tell me what perfusion means?
The blood around.
Okay, but what specifically about the blood?
Oxygenated blood.
Right, right. Perfusion is the state of getting oxygen to tissues and organs that need it. Hypoperfusion, as we learned in day one with our med term, what does hypo mean? Right, so this hypoperfusion, the definition is shock, but it is that we are not getting enough oxygen to the cells that need it and they are dying. Okay, inadequate perfusion of bodies, tissues, and organs. Hypoperfusion is the state of shock. Oh, see, she put it in there and I just didn't click fast enough before it said it. So pay attention to this. All of your shock states are going to fall within one of these categories. It's either going to be obstructive, distributive, cardiogenic, or hypovolemic. They can mix and match, especially in end stages, but for your base knowledge right now, this is something you should have like down pat cold. The way I like to think about these, and I'll give Mr. Hoover a chance to explain how he thinks about shock. And you're just going to have to find a way that works for you. I'm a simple-minded man. So I go to like pumps, pipes, fluids, and roadblocks. Okay. Those are my four. So cardiogenic is my pump. When my heart is failing, it is cardiogenic shock, right? My pump has failed. So that's The pump, cardiogenic shock, is the heart failing. Pipes is going to be distributive. So I think about this like a garden hose, right? If I hook my garden hose up and I'm watering my wife's garden and I like turn it on, I have good flow, good pressure. But what happens if I took the same amount of flow, the same amount of water and pressure, but instead of putting it through a garden hose that was this big, I put it through one that was this big? What would happen? Not enough diameter, right? Or too much diameter. Your volume's the same. You have enough fluid in there, but your diameter is too big. Well, that's what happens in distributive shock. That, and like if you stuck a bunch of holes in your garden hose, you would have fluid that would leak out of it. And that happens in things like septic shock, anaphylactic shock. Those are distributive kinds of shocks because the vessel that carries it is failing. So the method of distribution is gone. Okay. Hypovolemic, super self-explanatory, right? We're low on volume. Okay. This is going to be your hemorrhages and your severe dehydrations. You're low on volume. The top two things that's going to cause this is going to be if you're bleeding out, or if you had like nausea, vomiting, and diarrhea nonstop for 24, 48, 72 hours, that'll cause that too. Obstruction, I want you to think about this as a roadblock. So if I'm driving to Austin or driving to the mine or whatever, and there's like 6 boulders in front of me, it's an obstruction, right? Well, your obstructive shocks are going to be things like pulmonary embolisms, right? Because you're obstructing the flow. Nothing is wrong with my pipe. Nothing is wrong with my pump. And I have enough fluid in there, but I have an obstruction. I have a roadblock. That's going to be your pulmonary embolisms, to an extent your MIs and your heart attacks, even things like cardiac tamponade, where the sac around the heart fills with blood, doesn't allow it to expand. Things like thank you guys, tension pneumothorax, right? You have that pressure that's obstructing the expansion of the heart and the lung, okay? So think about obstructive shocks as a roadblock. Mr. Hoover, do you have anything you want to add to that, or do you want to say on that? Good.
Can you touch on the distributive again, like the difference? I get
Yeah.
distributive mixed a lot.
Okay, so you get obstructive and distributive.
Yeah.
Okay, so
Obstructive is a blockage.
is a blockage. Distributed is like the method that is carrying it fails. Okay, so everything is fine. Like there's no roadblocks, but your pipe just got bigger and it's leaky. Yeah. Yeah. So the best way I could think of it is literally like if you took a garden hose and that garden hose was 2 times the size it normally is, right? You're going to go from a strong, steady stream to like a little trickle. And then if you punched a bunch of holes in it, right? Could you see how you can't perfuse a garden if you can't get enough water to the garden because your vessels are too big now? Okay. And they can be a little bit confusing. The way I think about this is distributed is a pipe issue, especially for you guys that are mechanics. That you can probably like latch onto that pretty easy. Pumps, pipes, or fluids. So distributive is a pipe issue. There's a problem with the pipes. Obstruction means there's a roadblock somewhere. Cardiogenic means my engine has failed, and hypovolemic means I ain't got no gas in it. Okay, does that work for everybody?
Yeah.
Okay. We're going to touch on this a lot. This is an important concept that you need to have down because you'll get tested on this. And are we treating these all really different? No, not necessarily. Like when we treat for shock, it's kind of the same, but it's good for you to be able to clinically differentiate what is happening with your patient. Okay, volume problems. Okay, it's pretty self-explanatory, right? We're taking vital volume out of the system. Okay, if you don't have enough blood, then you don't have the oxygen carrying capacity. You don't have the ability to regulate the temperature. You don't have the ability to do pretty much anything. Form a clot, regulate your electrolytes. Like you lose all of that. 90% of the time it is from blood loss. And I mean, if you have a garden hose and everything's working fine and your pump is working, but you don't have water coming out of the spigot, you're not going to be able to water the garden if you don't have any water to water it with.
What would plasma, like the relative
So I think it's just kind of, I think she's just trying to allude on, like, if you take out the primary function of plasma, you may not be super volume depleted, but the functions of plasma are not there. What does plasma do?
Think about like dehydration, right? Like if I'm dehydrated, am I losing red blood cells?
No.
Losing plasma, right? The water.
Stuff that makes everything slippery to make it move and do it.
Plus, when somebody has like cellulitis and that fluid coming out, is that
Yeah.
plasma?
I mean, yeah, like plasma,
Kind of.
third spacing, fluid, right? 'Cause
Yeah.
Remember too, like you have fluid in three compartments essentially, where like you have fluid inside your cells, you have fluid outside your cells, and then you're in your central spaces. So like, it's not necessarily the plasma per se, but like the plasma contributes to the watery portion of your water.
Okay,
Nourishment,
okay.
yeah. Basically like a nourishment, kind of. Like water nourishes.
I would say no. I would say no. Well, I mean, it's going to be a component of it, right? It's going to be a component of it, but like overall, like plasma is not the only thing that carries like electrolytes and stuff like that. You know what I mean? At least I'm not that I'm aware of. Like, so the question was, would you say losing plasma is like losing the nourishment side of it?
I mean, to some extent, but
Not
to
fully.
some extent, no.
Yeah. Pulp problem is going to be your cardiogenic shock. Okay. When we talk about the heart, what kind of things do we think is going to lead to cardiogenic shock?
So would it be more of a bit or would it be more of
I mean, I guess technically both of those could be cardiogenic shocks.
They could hook into.
Yeah, like they could lead to cardiogenic shock. Most of this is what it's talking about. It's going to be a failure of the heart in the sense of like congestive heart failure, right? Like you have a heart that is just been like beat down, wore out, hypertension for 40 years, had a lot of heart attacks. So you had dead spots all over the heart.
Right.
Yeah, the mechanical part. So basically it's that the heart cannot pump hard enough to move the fluid where it needs to go anymore. So what happens in cardiogenic shock is you have that fluid start to back up into your legs, which is what side of heart failure?
Right side.
Good, right-sided heart failure. When it starts hitting the lungs, what side of the heart is failing? Left side of the heart failure, right? That big left ventricle that likes to, like the big workhorse of the heart, starting to fail. That's where stuff starts to build up. So this is a more than likely going to be a mechanical failure of the heart. And this is where I said, like, you can start in kind of an obstructive shock with an MI, but if enough heart tissue dies, that heart doesn't have that to beat anymore, it'll turn into a cardiogenic shock. Obviously, if you can't pump the blood effectively, you're going to have a drop in blood pressure. A lot of times these people either need like an artificial heart transplant, or they're like aggressively medically managed or paced, right? Something to give the heart what's called, I want to say it's inotropy, like that ability to get some squeeze behind it. Mike, do you want to add anything on this?
No, like just like I would say, just remember like the number one cause usually is like an MI, right? Like heart attack is going to cause cardiogenic shock. CHF, that's like an acute form of cardiogenic shock. Same like your, I think it was your student, like mentioned, this, like electrical problems, right? Like, think about bradycardia, right? When my heart is way too slow, my blood pressure's dropped. Like, that's not because I'm hypoglycemic, right? I don't have the pipe problem, it's the pump problem, right? So like that would be cardiogenic shock.
So I thought I heard you say that MRI was an example of obstructed.
So yeah. Then this is where I was saying like it's a little muddy, right? Like you can have acute obstructive shock from an MI, but it can transition into cardiogenic shock. Okay, is that fair to say? Yeah.
I mean, I see what
Yeah.
you're saying, right? Like, but I would say, like, if you want to think about growing a little clot in your coronary and causing a heart attack, it's like an obstruction, fair?
Yeah.
But like, that will cause cardiogenic shock.
Yeah, that's what I'm saying. Like it can start as an obstructive style of shock, but ultimately, I guess make this correlation. If it has to do with the heart failing, it is cardiogenic shock. Okay, that's probably a better correlation to make.
I can see how, I mean, probably any of these can cause other types of shock. Or they could.
Well, and everybody dies from uncompensated shock in the end anyway. Okay, so a blood vessel tone problem. What kind of problem is this? It's a pipe problem. Can anyone tell me your two classification would cause it if you have that disassociation and now you're losing vascular tone? It's going to be septic shock, anaphylactic shock, and neurogenic shock. So all your blood vessels are dilating at the same time. Blood cannot fill the entire circulatory system. So if I had like a cup of water, 16 ounces of water, and it's sitting in a 16-ounce Coke or whatever.
Wow,
And then
look at who came prepared.
Yeah, right. Well, so if I was to pour everything in that little cup right there into this one, it's not enough to fill it, right? It's not enough to perfuse it. That's a really good analogy. Good job. Good work.
She read into the book.
No,
That was good.
I was just trying, I thought that I was.
And it's a problem with the distribution.
I just thought,
I just wasn't thinking about the blood vessels dilating. I was thinking of like, why wouldn't it be going to the blood vessels? Well, then it's an obstruction, then it'll be obstructive.
Yeah.
But the dilation. of
but
the
just
blood
changes the shapes, yeah.
Yeah. All of these three caused your vessels to dilate, and then most of them will cause it to become permeable, which means you can start leaking fluid out of those vessels at the same time. So you just tripled the size and now it's leaky, like you're not going to perfuse very well. Yeah, absolutely. What is septic shock? Good, a system-wide infection, right? Okay. What about anaphylactic shock?
Either airway or reaction.
Can anyone brownie points if anyone can tell me how these actually lead to a distributive shock?
Your blood vessels.
Yeah, I mean, so I guess more specifically, like anaphylactic shock leads to the same, septic shock leads to the same, but how do they both lead there? Because there's two different pathways.
So anaphylactic was an increase of histamines, right?
Yeah.
That cause the blood vessels to have an overproduce. They perfuse. Yeah, they change in diameter as a response to the
Histamine.
overproduction of the histamine.
Yep, your body's overly attacking itself at that point. Septic shock happens because of the infections, and you have same thing you have.
Right, overproduction of white blood cells. And so the leukocytes respond by dilating.
I think it's mast cells too, right? No, mast cells get dumped in septic shock.
Yeah, I mean, we give a lot of shit. I'll give you guys a little bony.
Whoa.
That's nothing.
You're gonna give them a what?
Can you have anaphylactic shock the first time you were exposed?
No.
Yes.
Yes, you can.
Yes.
Well, the book says.
I thought they
it
said
starts
the
on
first
second.
time that
What did
you,
I tell you guys last week? Like, go with your gut and don't change your answer. The answer's no.
Yeah.
Right? No, you can't. Okay?
No, because.
But you can have an anaphylactoid reaction. It's the same thing. It's like a different. So in an anaphylactoid reaction, you can have a first time exposure and have that reaction. But it's not considered like a true anaphylaxis reaction because that's a different.
Oh, because my son, the very first week in components, he had like all those, the swelling, and crying down his face. There's an anaphylactoid.
Yeah, so like anaphylaxis is started with IgE, like that's the immunoglobulin that kind of gets involved in this. And so when you consider the textbook definition of anaphylaxis, like you cannot have an anaphylactic reaction on your first exposure, like physiologically, but you can have an anaphylactoid reaction, which is not IgE, it's like IgD, I think is what it is. But from that point forward, it's all the same.
Yeah.
And so that's why you have like people who have a first time exposure and they look like they're having anaphylaxis. It's just two different starting points basically, but they get you the same thing.
I just realized it'll be worse the second time.
they're both treated the same.
So does it, I don't remember this in the book, I mean, I know it says it. Does it get worse each time or just the second?
No,
No.
it's like the second time.
Yeah.
From that point.
So, let's say you have a third response, is it gonna equate like the same systems to the second response? Or could those systems change? Like it might still be anaphylaxis, but let's say the first time you had like it's anaphylaxis solely.
Yeah, but even not that.
Or sorry, not
Yeah.
anaphylaxis, but airway stuff.
I mean, you could theoretically. right?
Yeah.
Yeah, maybe the first time
Changing
you have
systems.
two systems and then the next time it's two different ones, but at the end of the day, two or more systems. is
It's still
the same.
anaphylaxis.
Can anyone tell me how neurogenic shock leads to a vessel problem?
I mean, your brain controls like your vessels constricting and dilating. So if you lose that connection, like you're gonna lose the vessel tone. So like if your spine severs,
Good.
you're just gonna lose the ability to control it.
Yep.
Decompensated shock though, you lose your ability to compensate.
So decompensated shock, it can lead to it. The only thing you need to tie that to is blood pressure, right? Their ability to maintain a a state of perfusion. As soon as that blood pressure shifts, like that's what's going to classify as decompensated. Yes, you're right. You have a disconnection, right? Your body's not talking to it anymore. So, your receptors are not saying, hey, we're in trouble, squeeze, 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 because it can't hear that anymore. So, yeah, absolutely. Good job, Billy. Okay. Obstructive shock. These are going to be your big three: PEs, cardiac tamponades, and tension pneumothoraxes. You have roadblocks. Okay, you're trying to get somewhere and you just can't go past it. Think about. We'll start with a tension pneumo, right? You have pressure that's building in the chest cavity, putting pressure against the lung and the heart, keeping it from expanding. Okay, that's what's going to take your blood pressure and kill you. So it's an obstructive shock. Cardiac tamponade, same thing. You have blood filling the sac around the heart, which guess what? Like that means that now that heart that does this cannot expand against that blood. You means you can't circulate that blood. Okay, like your pressure's gonna dump. And PE, I mean, we all kind of know what a PE is. Okay, but do we actually know what that like means? What that is? Good. Yeah, you're hitting roadblocks.
Well, it looks like a whole tree when you pull it out.
Yeah. Can anyone for funsies tell me who is at the highest risk or which demographic is at a fairly high risk of PEs?
Marcus.
No.
No, that's new
Oh,
most, yeah.
Yeah.
Women? No, that's for kidney stones or gallstones.
It's not, isn't it women in their 40s?
So it's going to be women who have taken oral contraceptives and smoke. You, uh,
shot one?
no,
Any
if
type of contraceptive.
any type of contraceptive, so women who smoke with any type of contraceptive is at a like pretty significant increase for PEs.
Is it specifically smoking or also vaping?
I don't think we've had vapes out long enough to know. I would not be surprised. And some of the trashiest lungs I've seen in the last 5 years have came from COVID and vapors. I've seen like 24-year-olds with the lungs of 80-year-old minors that have, sucked down silica for the last 40 years from vaping for 2.
So if you put vaping, if your lungs full and like back, or
Pretty much everything in your body can heal if you give it the right nutrients, the right time. Go to yoga, meditate, eat
You
good
have to do
food.
yoga?
Dude, I'm crunchy as it gets. I don't even, this phone goes into EMF shield at night. Like our Wi-Fi gets cut at night. We have like,
the tinfoil pretty much. Like
Yeah.
where it's- I don't know how to explain it.
You don't put it where she's gets
does anyone know how to play this? Does anyone know how to play these videos that she put up?
They would have to
It
have
used to
a
be-
hyperlink unless you can can you right click it?
What about down there on the
Does it have?
word right hand side? Underneath the .com thing?
This
The other way.
The other way.
You're right, yeah.
This way?
The other purple one.
The other one.
What
Or
purple
blue.
one? Dude, what are you
Yeah.
looking at?
Where it says
Turn
.com.
around.
underneath.
Oh, I don't have this on this thing right here.
No, the
Yeah.
other, on the other corner.
Oh, see, I don't have that on my thing, bro.
What do you have?
What does it show?
Okay. We're gonna skip it. Okay, before we go into this, can anyone tell me what hormones are released and what the sympathetic nervous system is? Okay.
What you said and what the sympathetic system is?
Yeah, someone describe to me what the sympathetic nervous system is and what hormones are released.
So the butterfly, but it-
Good, epinephrine and norepinephrine, right? Where are they released from? Good job, good job. Okay. Does anyone know what happens when epinephrine is released into the system? Good.
Blood vessels constrict.
Heart rate increases, blood vessels constrict.
Can-
What about your lungs? Because we give this drug in anaphylaxis, right? And we give it when people are dead too, but we give it in anaphylaxis because it reverses all the bad things. Bronchodilates, right? So what does that mean? That means like my pupils do this, I get hyper focused, my heart rate shoots up, my lungs can bring in more oxygen to feed more cells. Like this is literally gearing us to survive whatever comes our way. Now we're in a different state now because now people get their fight or flight like amped up for like very little things, and we're not fighting tigers anymore.
Would it be like hard to, for like if you gave someone who was on a beta receptor, right, epinephrine, would that be hard because like it doesn't increase their heart rate?
So someone who's on a beta blocker, if you gave them epinephrine,
It depends on what type of beta blocker.
the epinephrine would still the epinephrine would still work.
It just wouldn't increase their heart rate?
No, I'm pretty sure it would. I'm pretty sure it would. No, it wouldn't at all.
I mean, you're not gonna get it like kind of to Billy's point, like it depends,
Yeah.
right? Like they make cardio-selective ones and blah, blah, blah. But the reality is like nothing is 100%, right? Like
Yeah.
even though it's cardio-selective, like it crosses.
And it
So-
depends on like different dosages and because
Yeah.
epinephrine works on different things at different dosages too.
So would you have to like up the dose for somebody on it?
You like maybe, right? And same thing, like it kind of depends. Like, okay, so I'm on let's just say for argument's sake, I'm on a cardio-selective beta blocker. and I'm having anaphylaxis, so you give me epi. Like, okay, yeah, maybe I don't get much of a bump in my heart rate,
Which
but
you're
I
gonna get
still should
squeezed.
get blood vessels,
Yeah.
right?
Like all that stuff was still.
Yeah.
Like that still make you have like a bronchodilator.
And a vasoconstrictive
Theoretically.
response.
Yeah.
So remember the textbook definition of adrenaline is it's a non-selective alpha and beta agonist. Okay. So it's working off alpha 1, alpha 2, beta 1, beta 2. Now, if you're on a heavy dose of a beta blocker, like you probably, I guess you're probably not going to get a lot out of that, but you're still going to get the rest of the effects. Okay. We just talked about what a dump of epinephrine does. Pediatric shock, infant and children's. Kids are really good at compensating blood pressure until half of volume is depleted. Remember, they have less volume than us, so that's going to happen a lot faster. They used to say that like kids would do this, right? They'd hang out, and then like hard crash. There is little tell signs to show you that they're kind of dipping. How an adult kind of goes like walking down the ladder. Kids do maintain here a little bit better until they literally can't compensate anymore. That's because they burn through sugar like crazy too when they're in shock. Okay, they rely on their heart rate.
Whereas an adult, you would see a drop in blood pressure, and that's how you know they're decompensated.
Yeah, so in an adult, you will see it, and like depending, right? Like, you know, if they just got shot in the chest, like it's gonna go a lot faster than you think. But like, let's say they have like standard septic shock, like you will see them go from like blood pressures in the 130s, then to the 120s, then to the 115s, then to the 90s, then to the 80s. And you'll see their heart rate do the exact opposite, right? It'll be 100, 120, 130, and so forth. The blood pressure and your heart rate do a teetering effect, and that's called shock index. So whenever your heart rate is higher than your systolic blood pressure, you have a shock index greater than 1. That is a pretty good indicator that your patient is starting to decompensate. Stages of shock: compensated, decompensated. Muscles are running out of fuel. Your BP starts to drop, and this is like, just think about this as a hard stop. Like, compensated is like, yeah, they're in trouble, but they're still perfusing. Decompensated is like, we are no longer perfusing. Okay, we are losing this fight now. Drop in BP, drop in mental status. You can look at their skin signs and symptoms. Pretty much anything that'll cue you into like their end organs are not getting the fuel it needs anymore. Irreversible shock, they're going to die. All uncontrolled shock leads to death, and ultimately everyone dies from some sort of shock. So our body has natural mechanisms built in to try to compensate. Our pulse being one of those. Like we said, when we release epinephrine, it causes our pulse to go up, it causes our vessels to constrict, it causes our lung to dilate, our respiratory rate increases. And have you guys ever had that where you got like scared or like something happened and like you got that kind of hot feeling in your stomach and got a little bit cold? Yeah, that's that blood shunting. Okay, that's your body putting you into fight or flight and just preserving everything for your vital organs. So that feeling when you like your stomach gets hot and your hands get cold, that's that drop. This is something you really, 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 really need to know. They've recently added a third and called it a diamond. Your book doesn't cover that yet. Don't be surprised if that changes in the next couple of years for even the EMT level. But this is the trauma triad of death. Everybody take a picture of it, write it down, remember this. So when Mike took you through hematology, what did you learn about like the clotting cascade and how the body fixes itself? Anything at all? Do we remember? Okay. So you have your extrinsic or intrinsic pathways, whichever one. Your body goes through a big long cascade and it tries to heal itself, right? Forming a clot and stopping a bleed. Here's the problem, and this is why when we drill into you treatment for shock, it's so important that you do the little things. And this is where paramedics fail all the time, because they're like, I'm a paramedic, I can give you drugs, and I think that I'm special because it says paramedic, and it turns out I'm just a dickhead, right? The basic treatments for shock are so important because it reverses, or at least tries to treat, the majority of this trauma triad of death. So what happens when we lose blood? Can we regulate temperature? No. Okay, well, look here. If we can't regulate temperature, it affects our coagulopathy. It affects our ability to form a blood clot. Well, what happens if we can't form a blood clot? You have acid that builds up, okay? So what is our normal pH? 7.35 to 7.45? Okay, when your acid starts to build, you also can't really form a clot that well. If your acid, and by the way, your acid window is this big, and you cannot live that well outside of it. Like, you have to have some serious compensation for a long time. You have to go back inside that window relatively quickly.
Can Tums really mess up that acid?
100%, dude. It's straight what? What's Tums? It is alkali, right? It's straight what, though? Calcium carbonate? That's a straight up base. So, side note, that's probably one of the worst things you can overdose on, because there's really not a lot that we can do to fix it. Yeah, Tums, I mean, am I wrong? Right, straight calcium carbonate is a straight base. So if you yep.
Costco bottles.
Nope, not good. Not good. Anyways, I need you to recognize that this is a negative feedback loop. Each one of these affects each other. In fact, I wish they would make it just a big ass circle, because they all play off of each other and affect each other, and they keep you from being able to heal yourself. Okay? It was once told to me, because it's kind of hard to think about, like, okay, well, what is acidosis in my blood? And it was taught to me this way, that when you cook a steak, you're denaturizing your protein and it's releasing all the good stuff in it. And that as your body becomes acidic, that's doing the same. Okay? That just plays off of each other. So when we say treat for shock, I'm going to warm them up, that's not something that we should take very lightly. That's actually something that we should take really seriously, right? Like, hey, take the time to actually either warm them up or keep them at a normal temperature. They will lose blood very fast, and that's going to affect their ability to regulate their acid, their pH balance, and to form a blood clot. Hypothermia affects the body's ability to clot. Bleeding can be accelerated by underlying conditions. Okay, treatment for shock. It does depend on the underlying condition, but you're relatively safe to do the same 3 things for every shock, which is lay them flat, keep them warm, give them oxygen, and then you can throw rapid transport in there, okay? Obviously, the big one for us here is that if they're bleeding, you need to stop that bleeding. That is like step 1. We're going to lay our shock patient supine. That's going to have the least amount of cardiovascular workload. Prevent hypoxia, they need to be on high flow oxygen, prevent heat loss. Okay, we're gonna start getting into some of the bleeding stuff and how to treat it. Do we need to go over this in depth? We know why arteries spurt, because they're under pressure, right? Veins are steady, slow flow, and they're dark. And then capillary bleeds are slow, even flows. We don't generally have to do that much with capillary bleeds, but your venous and your arterial bleeds need to be addressed relatively quickly. Who Who remembers what I told them like last week about bleeding into your pelvis and your femurs?
You can bleed out your whole body.
Yeah, right. You can drop every ounce of blood you have, like from here down, and completely hemorrhage to death without ever dropping a drop outside. And as we talked about going through our head to toe physical assessments, one of the things I told you guys was to look for discoloration or bruising in the abdomen, which this is why. Because when you see that, your mind should go, oh, hey, they have internal bleeding, right? They're bleeding into their belly. External bleeding, 99% of the time it's going to be from trauma. The first thing we're going to do is compression. So we're going to hold pressure, and when we do direct pressure, it's not like a small amount of pressure. It takes a lot of force to help stop that bleed and promote that clotting cascade. How much blood we lose is going to be dependent on the size and severity of the wound, size and pressure of the ruptured vessel, and then the individual's ability to clot. Who do you think would have a decreased ability to clot? Well, I just told you that somebody that was hypothermic, right? But who else? Right? Blood thinners. What else? Anemia? Potentially, actually. What about some of your demographics that have, maybe they're not on blood thinners, but they have clotting disorders like factor 5, factor 10, von Willebrand's, like.
Aren't those super rare though?
Believe it or not, there is a yearly conference in Elko where they have at least 200 of these people from the region show up. Yeah. One of the ladies that works for EM in Elko is like part of that big group, and she's had, like, she actually carries her own factors with her everywhere she goes. Okay.
Isn't that like albino people? They don't have, or no?
I don't know. Is there?
Maybe not.
I don't know. That's a good question. I'm not sure.
Isn't there a conference in Elko every?
Yeah, there is. I don't go to it because I clot fine, so my clots are fine.
My clots are fine.
Danny said with them, it has factor 5 almost every generation.
No shit.
A lot of, like, when you look at the, especially like the hemophilias and stuff like that, like a lot of them are, there's a good handful of them that are sex linked. A lot of them are out of something like von Willebrand. But it's kind of crazy. Like, there's a lot of them. Like, you don't think about it, right? Because we have small areas.
Yeah.
But then, as you learn, like, it turns out there's a decent amount of people, like in this region, that have some type of clotting disorder. And that shit is expensive too. Like, for them to carry around the stuff, I mean, you're talking tens and tens and tens of thousands.
Yeah.
Do you think it could be like because of the region?
Yeah.
Like,
He doesn't have factor though. A factor deficiency.
Could be.
Like, for example, like in Idaho, Silver Valley.
Oh yeah. Okay.
He just carries.
Dormant.
Has it.
He's dormant.
Yeah.
Gene has it. Hey, did you check your patient this morning for fucking bleeding?
Which one?
No. Never mind.
Like, hold on, bro.
No, never mind. Okay. What is this? What do you guys call that? An abrasion, an avulsion, an amputation? Okay. I'm not 100% sure what they're teaching you about amputations and tourniquet usage. I can tell you that the TECC, I don't know, my eyes aren't that good. Some, like the military right now is teaching that everybody with an amputation gets a tourniquet placed. I'm not sure if that's what you're teaching right now. But. Does it? Okay. Size and pressure of the ruptured vessel. Have you guys seen? Did everyone see the video of the guy that went to his ex-girlfriend's house, punched through that window?
Oh yeah, he had just gushed everywhere.
Yeah, he died.
Really?
Yeah, he died.
I would say that was a lot of blood really, really fast.
Yeah. So if you nick a major artery, like I'm talking like brachial, femoral, obviously like a carotid, something like that, you can hemorrhage in a matter of 2 minutes.
Yeah, there was a cop that was chasing the guy. It shows it on where it shows him. He's on one through a window. Luckily, there was another officer right there to tourniquet him.
Yeah.
He would have died.
That's why I was gonna say, if you want to put direct pressure on that.
Well, so here's
That's
it's
crazy.
that one would be pretty tough, right?
Yeah.
But that's like That's probably your best starting point every time, unless it's literally something that you can't put direct pressure on and like you have to tourniquet. But direct pressure is like will stop most bleedings and it'll help you transition into a tourniquet. Okay. First thing we're going to do is identify and control massive hemorrhages within the first seconds of a primary assessment, right? What is one of the first lines? It's identify like patient life threats, right?
Yeah.
So we stop bleeding first. Ensure an open airway, ensure adequate breathing. And then this is going to be like a secondary assessment thing, but like your non-massive bleeding only after assessing and treating the prior elements. So this actually has shifted from when I went to EMT school. When I went to EMT school, it was like airway, breathing, then circulation. Now it looks like massive hemorrhages need to be treated first, which makes sense, right? If somebody's like spurting blood out and I'm breathing for them and I never stop the blood, like, yeah, it makes sense, right? Ooh, sweet. The March algorithm comes out of the TECC committee, which is Tactical Emergency Combat Care. This is actually my favorite. I prefer March over like ABCD or XABCD or CAB, whatever they're. This is my favorite. Massive hemorrhaging gets treated first, airway, respiration, circulation, and then hypothermia or a head injury. I like that they put hypothermia in there. We need to put more of an emphasis on treating people's temperatures. That's really the only way you're going to give them an ability to heal themselves and clot themselves.
But that would apply for mostly a trauma assessment, right?
It would apply for mostly a trauma assessment. Oh yeah, sorry.
They showed that at the trauma assessment.
The March, yeah.
March and XABC.
Yeah, I don't care which one you want to use, man. Like, please do whatever Becca and Chaz have taught you to do to start to get through the class. But once you leave this class and decide you want to start practicing, if you want to, and you want to go with March instead of XABC, like, I don't care. He's at something, I don't know, he told me last week and I forgot.
Oh, it was a BLM training, right?
Yeah. Okay, methods of controlling massive bleeding. Someone give me a guess before I click. Direct pressure. Boom! Direct pressure. Right? Winner, winner, chicken dinner. This is a safe bet every time. Realize it takes more pressure than you think it does. You have to like actually put some force into it to help that clotting cascade and compress those arteries and whatnot.
So like fist balloon?
I mean, depending on the wound, I guess if you had a massive laceration in the femur,
What if
and
it's
you're
like in utero?
maybe you had bleeding in utero and you wanted to fist it. Yeah, I mean you could try quick clot. I think quick clot's fine.
I had sometimes they have a balloon, but they just kind of massage it and then I don't know about
So does it like
Trick it to
stimulate it or
contract.
something? Oh, interesting.
You're talking about fundus massages?
I don't know.
You guys will learn that in your OB section. Okay, direct pressure, always a safe bet. Quick clot, so there's a bunch of different hemostatic agents, okay? You have quick clot, you have combat gauze, you have Z gauze, you have this new gel that's in like a syringe that you stick in and then you compress, and basically they all have the same function, is that they promote the clotting cascade in one way or another. I want to say it's called like xylene or kaolin or something like that most of these have, and it's like a shell derivative of shrimp that promotes your clotting cascade. If you're allergic to shrimp, it's said that you're not going to have an anaphylactic reaction to it, but the big thing to remember is that the hemostatic agent has to go directly on the wound first, and you have to hold it there for 3 minutes for it to work. Okay? So if you shove a bunch of normal gauze and then your quick clot's not doing shit for you other than being normal gauze. And if you shove it and don't hold pressure, it's not activating anything, okay? So your hemostatic agents have to be held directly first in the wound for 3 minutes.
Those are the ones that you can't. Those are the only bandages you don't want to.
So we're not going to remove bandages once we start because you can actually rip any clotting that's happened out, okay?
Be an exception to that if you were like get there and they started using normal bandaging or normal stuff and you have to use
I would, that's kind of a tough question. So here's what I would do. If you get there and they have a bunch of normal gauze and they are still like hemorrhaging and that is not stopped, I'm not going to peel it. I'm going to throw a tourniquet on. Now, if it's a junctional wound and you can't put a tourniquet on it, fuck, dude, what would you do? So you have a junctional wound or you have any wound and you get there, someone already started with normal gauze. Would you take normal gauze out to put a hemostatic agent in?
I don't know. That's hard, right? Because like to be fair about it, I'm not exactly sure like what the current thing is. I know a few years ago, like they were talking about like if you had wrapped a wound or even packed a wound and like it is still hemorrhaging, then the recommendation actually was to pull it out because at that point, like it is hemorrhaging, you know, you're not putting pressure on the artery or vein or whatever vasculature in there, and chances are they probably don't have a clot because they're still hemorrhaging, right? So, but I don't know if that's hard. I think like I go back and forth on this, right? Like if there's hemostatic gauze in there, like part of me wants to say I would just pack more into it. Part of me wants to say if it's still actively hemorrhaging, then obviously it's not working. So pull it out and try to get another good chance. But same, I think like, I don't know. I mean, I think the safest answer is like, if you're at that point and it's still hemorrhaging, I would just put a tourniquet on.
Yeah. Yeah, I would throw a tourniquet on. And then if it's a junction and you can't tourniquet it.
If it's a junction, like I would probably pull it out and try it.
Yeah. But I wouldn't pull it out to put hemostatic to end up tourniqueting anyway. Like if they're hemorrhaging and your direct pressure is not working, you need to throw a tourniquet on relatively quickly. Because like I said, you can hemorrhage in like 2 to 4 minutes.
Yeah, I'm trying to, that's what I've been doing. I'm trying to find this damn video. There was actually a really good video. It was like a robber. This dude gets shot in the leg. And it's quick. Like he loses consciousness in like
45 seconds.
Yeah, like 30 seconds.
Yeah, you lose the ability to help yourself relatively fast. Was it the dude like in Nigeria and he took an AK around to the femur?
I can't remember something, right? There's like 3 people there, and then like he ends up taking around to the leg, and within like 30-ish seconds, like he's fucking unresponsive.
Yep.
Pretty much.
They should have hurt you, Mark.
Was it Sean Burke?
I think so.
Yeah, that's where I got it from. Yeah. So 2 to 4 minutes to die. You probably have roughly a minute to save yourself before you like lose the ability to make a conscious choice.
That video, the guy punches him.
Yep, that guy did end up dying, right? Clipped.
There's
There's
another good one too. Like if you guys can find it, it's like super interesting. It's this dude on a mountain bike, and he's biking with his friends, but they're all doctors, like surgeons and all kinds of crap. Anyways, he wrecks his bike, but he punches his brake handle like right into his groin, and it rips the wrist from horrible. And luckily, like he knew exactly what it was, right? So like he puts pressure on it, and his buddy behind him saw it and sticks his knee in it, and like had they not done that, he would have died.
Yeah. I had to do the same on my first time like ever. I was working in Elko County and I had a wreck up on the summit between Elko and Spring Creek. And actually, I don't even think I was working. I think I was in my internship, and kid lays a bike over, shatters, like bones sticking out. He has ripped through his shit. And I was so used to like patty caking this on mannequins and like the mannequin never reacts, right? So as I'm like touching his wounds, trying to stop the bleed, for one, I wasn't doing it effectively because I wasn't putting the pressure I need to. When I did, he tried to gouge my eyes out because he's in a lot of fucking pain, right? And he's losing a lot of blood. So just like be cognitive that it's not going to be like when you're packing these mannequins here later, or tomorrow or whenever we pack them. It's going to be fucking painful. It's going to take a lot of force, and you're going to have to get pretty invasive with it. Okay, tourniquet placement. Current literature is going back and forth. I'm not 100% sure what your book says. I'm confident Becca's going to put it in here though. 2 to 3 inches above the wound off of a joint. Some literature says high and tight is okay. These junctional tourniquets are extremely expensive. There's not a lot of great data on there. They take forever to put on. We don't carry them. Most agencies that I know don't carry them. We actually do like some janky makeshifting of them. Yeah.
I have a question about.
Yep.
So that situation you were in on the past. When the patient gets violent like that and you're trying to help, like, how do you handle that?
Sedate the piss out of them.
Okay, but you patty cakey, you had no experience, you can't sedate them, right?
Yeah.
We can't sedate them.
Yeah, it's tough, dude. Hopefully you have people there to help like restrain them.
Okay.
And just try to be as professional as possible. But you have no choice, right? You have to get that bleeding. So what I ended up doing was like shoving a bunch of gauze in there and putting all 200 pounds of my knee into that one area, and then doing like a bunch of pressure dressings while my partner, because I was in medic school at the time, but the guy I was running with actually sedated him. I'm not gonna lie, right? Had I not been able, I'm not gonna sit here and be like, oh yeah, you just have to do this. Like, it's gonna be a fuck situation. It's a no-win, right? Like, it's a good luck situation.
Like holding them down, that's not like, hey, you passerby, I need you to hold it down so he doesn't attack me while I try to.
No, yeah, that's probably gonna be like, other EMTs, sheriff's office, firefighters. If you have some passerbys that are about it and they'll help, I'll take all the help I can get in that situation. Other methods of bleeding control, we can elevate above the level of the heart. Do not elevate if musculoskeletal injury, impaled objects in extremities, or spinal injury is suspected. Splinting, stabilizing sharp ends of broken bones. We always splint above and below the injury site. And then air splints and vacuum splints, just helping keeping that from bouncing around, and those bones rubbing can help. Cold packs. These are probably not going to be your go-tos and like massive, but like some capillary bleeds and stuff like that. This will probably be pretty helpful. I wanted to cover something. There's also what's called like a pressure bandage. It's kind of like your meat in the middle, where you can just wrap the piss out of them and tighten an ACE bandage down, or they have what's called like Israeli or actual pressure bandages that they don't need a tourniquet, but they need continuous pressure to stop it. Like that can help you there.
I like the Israeli bandage.
Do you?
Yeah.
Yeah, they're not bad.
Well, that's what I was trained with. So.
Yeah, they're really good for junctions where you can't tourniquet. Head injuries. Do not put a lot of direct pressure on like head injuries. Why do you think that is?
You go right through the brain.
Well, so what happens to the brain? It swells, right? So it needs room to swell. Okay, so if you have like an open skull fracture that's bleeding, put a little bit of pressure on it, but don't stop it from swelling. Okay, you want that fluid to release. You want that tissue to be able to swell out.
There's nothing that we can do if they're hemorrhaging
It's actually kind of hard to hemorrhage out of your head. Like it looks bad, but you don't have. Fuck man, maybe I'm talking out of my ass here. Like.
Yeah, I would say like.
Yeah.
Apply a little bit of common sense here, right?
Yeah, like it's not.
If you have blood coming from your ears and your nose, like, right, like if you have like a scalp plaque, right, like, I mean, those things will bleed like a septic. But you need to control that, right? If you have like an open skull fracture, usually like the bleeding that you're looking at is like from the vasculature of the scalp, right? So like kind of the same thing, right? Like, yeah, we need to kind of do some stuff here, but we're not gonna like put a knee through this guy's cerebral cortex, right? Like, does that make sense? I know it's not like a good answer, but at the same token, like that's the reality of it, right?
It's just a situational thing.
It's tough. It's tough, right? You don't want to increase our intracranial pressure by stopping blood from escaping the skull.
So no like hemostatic agent.
I'm not opposed to hemostatic agents at that time. No.
What about like cold packs to like slow it down? Because that's not a lot of additional pressure, but.
Yeah, if you can get to that point, right? And I mean, like, your hands you're going to be pretty tied up. If they have an open skull fracture, you're going to spend the majority of your time on the ABCs, and the cold pack's probably not going to come into play. If you've knocked out the ABCs and you have time, like, hot dog, dude. Yeah, for sure.
Wouldn't the brain swelling kind of shunt the bleed in a way?
Depends where the bleeding is, depends where it's coming from. You know what I mean?
Yeah, I mean, like, I think if I'm understanding your guys' like question or concern here, like, if you have a hole in your head, like communicating to your brain, like you're not gonna bleed 4+ liters of blood out of that, if that's what you're asking.
You're not going to hemorrhage out of there,
Yeah,
right?
like,
So
a
it's
lot of that bleeding is like from your scalp, right? So, and then also like to some extent, same kind of thing, right? Like at the end of the day, if you have brain sticking out and you have like this arterial hemorrhage, like, are they gonna bleed to death in the next few minutes? Versus, like, yes, the brain injury is bad, right? And herniation will kill them. Like, that's not gonna happen in like the next 2 minutes, right?
It's just the what's the more.
What's the
imminent,
more
like,
Yeah.
severe thing, like,
Yeah.
I have a question that's kind of related. I feel like I should know this already, but
it's all good. I should know a lot of things I don't know, bro. It's all good.
okay, so when you get a blood clot, if it detaches internally and it starts going through your bloodstream, it's a fresh clot, like can it disintegrate or is it just in your bloodstream? Remember where does it go out? Like are you just doomed until when it finds your lungs, or does it disintegrate eventually? Does it cause something?
Good
it
question.
can disintegrate, Rick, is like, think about when I smashed my thumb, right? Like, I mean, there's a little bit of clotting down there in those vessels, right? Like, so if I were to just live with that for the rest of my life, like chances are I'm gonna throw some type of clot somewhere, right? So your body's it's always about balance, right? Gas and brakes, the teeter-totter homeostasis, so, right, kind of like, I don't know, like in my mind, I kind of think about TXA, right? Like TXA is one of those drugs we hear about to like help clotting and do all the things. And it doesn't actually promote clots, it just prevents your body from activating the system that would start chewing through and breaking them. So like if you had a little clot, right, floating around in your bloodstream, like luckily, hopefully it didn't lodge anywhere you don't want it to lodge, but yeah, your body would chew through it.
That's a good question. I mean, it really is, right? Have you ever thought about that? Like, well, I'm clotting all the time. How come I haven't had a heart attack or something like that? Epistaxis is a nosebleed, pretty easy. The steps to treat it are easy. If they're on blood thinners or something like that, they can actually be quite a pain in the ass to get under control. But we're going to lean them forward. We don't want to go back like we used to. For one, like blood is fairly strong irritant to the gastrointestinal lining. And we don't want them compromising their airway in any way, shape, or form, right? So we are going to lean them forward, apply pressure to the fleshy portion of the nostrils. I mean, I feel like most of us have had a nosebleed. The only time you're really going to have an issue with this is if they're on blood thinners. And I have seen like uncontrolled nosebleeds that actually get flown to bigger hospitals because they're just losing too much blood. If the patient goes unconscious, you're going to have to just suction and protect their airway. Okay. Internal bleeding is damage to internal organs and large blood vessels, can result in loss of large quantity of blood in a short time. Sometimes you're not going to see it like we already discussed, right? You can bleed into your stomach all the way down through your femurs, like in your entirety and never lose a drop outside.
That's great.
Yeah. Okay, some signs of internal bleeding, guess what, are going to be a lot like signs of external bleeding, okay? As far as like your skin signs and symptoms and your vital signs and your mentation and, like the myriop, just the differences. You're going to see, you could see injuries to the surface of the body, bruising, swelling, tenderness over vital organs, painful, swollen, or deformed extremities, bleeding from the mouth, rectum, or genitals. Tender, rigid, or distended abdomen, right? Ding, ding. That's one thing that we always check for when we're doing our head-to-toe assessment. And then any signs and symptoms of shock, pale, cool, clammy skin, low blood pressure, thready pulse, etc.
Do you get that pitting edema with internal bleeding? Like because there was all that fluid?
It's not going to be like a pitting edema because that's more like a third spacing kind of thing. What you will have is more like a hard belly. Right, it's not going to be like mushy and like it stays. Like you're going to have like you're going to touch it and be like, oh shit, this is fucking hard, right? The other thing I would encourage you to do is like when you go on car accidents, like go take a peek at the car, because the car will tell you the story of what happened.
Was that a urinary catheter in that last photo?
I don't know, I was avoiding looking at it, but now that I got it close.
I've never seen one before that's washed.
Yeah, that's a
Okay,
Foley cath.
okay.
I thought that too, dude.
And that looks like a pelvic fracture with maybe, that's what a femur fracture looks like, actually, a close femur right there. Big, swollen.
Twice the size of this.
Yep. Femur's a big muscle, right?
Yeah.
Holds a lot of blood. No, it's all good. I've seen him a couple times. I just, try not to look too much. What's he say? I've seen one or two, unfortunately. Hey, you guys need to grow up. Everyone in here needs to grow up. God.
Yeah, sure.
Blunt trauma versus penetrating trauma. Blunt trauma comes from falls, MVCs, auto pedestrian crashes, blast injuries. Right? Think about blunt force. It just means it's not actually transecting through your skin. Penetrating trauma, gunshot wounds, stab wounds, impaled objects. Both of these can result in very similar injuries and injury patterns, okay? Remember, be highly suspicious of bleeding into the pelvic cavity, and we're going to apply a pelvic binder. We're going to apply a pelvic binder if suspicion of pelvic fracture or mechanism of injury is significant. I think it's like if you have bilateral femurs, there's like an 85% chance that your pelvis is also broken. The big thing to remember with pelvic binders, and we will drill this skill quite a bit, is if you put it in the wrong place, you can make them bleed out faster, okay? If you do it right, there's relatively no harm that comes to the patient. I say that with like relatively no harm because there's always the potential of harm. But if you misplace it, it can be pretty catastrophic. As you guys can see up there, we have massive, massive vessels and arteries running up and down there. So we're trying to close all that up to stop the bleeding. Okay. That was chapter 29. Does anyone have any questions? I don't.
We haven't even done the homework for it.
It just opened up yesterday.
So I don't think
If
so.
you've worked ahead, you've done
Yeah.
homework for it, but the homework hasn't been due yet.
You found a find somebody, you're trying to cut off that blood flow, right? So that they wouldn't have fetal pulses?
No, you're trying to pull the bones back in the right place and keep them stable.
Okay. Thought it was also
Dude, how do I explain this?
So
Actually, you explain.
in your pelvis, right, like you have all the major vasculature built together, but like you also have something called your pelvic plexus. So think of this just kind of like intertwining, something like that. So what's common with pelvic injuries is like that gets disrupted. And so part of that, by putting that binder back on, like you're putting it back together. Granted, you're not gonna like fuse the vessels back together in there, but you're essentially creating like a tamponade to get that bleeding to stop.
Yeah.
So then the blood vessels wouldn't be restricted
No.
necessarily.
No, not necessarily, right? Like,
Flow back.
you're basically taking a gigantic open space where you could dump all of your blood volume into it and closing it back down so that, yeah, you're gonna bleed into it, but then eventually like the pressure in there will tamponade itself off and should refocus that.
Yeah.
Okay. It's just giving it nowhere for the blood to go,
Yeah,
and so it hopefully stays in the vessel
Okay.
from there.
yeah, theoretically, right? Like you're
So
trying
kind
to
of a dumb
basically.
question. Well, not
not-
really.
No dumb questions, Zog. What do you got?
Why did it take them so long
Kind
to
of put
realize
this
that
space
maybe
back
pushing
together instead of
backwards
giving
during
yourself
was bad?
like this giant.
Um,
like all of those spaces.
So I will say medicine moves slow. The AHA guidelines come out like every 5 years, and basically the way this works is you put 5 doctors in a room and say, agree on what needs to happen. Okay, I'll tell you this. I put 4 paramedics in a room and we can't agree on where we're gonna go eat, and everybody's right and nobody's wrong because we're all prima donnas. Now you take that and extrapolate that to the highest level, and in emergency room physicians and ICU doctors, they can't agree on anything. The truth is, where we sit in medicine right now, everyone's probably 5 years behind where we should be, and that's a rolling cycle. Yeah. Who here ever did any kind of EMS 5, 6, 7 years ago and did backboards? No? Yeah, so we used to put everybody on backboards. We had zero data. We thought it was a good idea. It turns out we were actually hurting a lot of people. Those hard, rigid seat collars, yeah, those should have been out 10 years ago too. Should have been out 10 years ago too, but guess what? We still intermittently use them. All the data now suggests that, like, no, they're not good. Yeah, it just takes time. It takes time. Yeah. And honestly, like, the nosebleed thing is probably the smallest of all of them compared to some of the stuff we used to do. In fact, I bet you in the next 10 years, the times you see an ambulance go lights and sirens is going to be so minute that it's going to be like, holy smokes, it's going to be like active shooter at the school kind of stuff. And it's not going to be, like, most of your ambulances are going to roll non-code from now on. Just because we have data now suggesting that, one, it doesn't save time. Two, it's a hazard. Doesn't do anybody any good. So, yeah.
I think it's
That's gonna be the same way with fire trucks too.
Yeah, no, for sure. It's be like you get on the open highway in a fire truck, you're going to only do 72 anyway, and you're like, anybody have any questions about bleeding control, shock, stages of shock? Sorry.
No, I like how you described the stages of, like, how you would think of shock, and that kind of dumps it down and makes it.
Well, I'm a simple man. Ask my wife. If you give me more than 2 tasks at a time, I will definitely forget the first one. So I have to keep things very simple, right? Like, I have to correlate them in ways that when I'm under stress, I can just be like, oh, this is this, and this is how I treat it, right? Blanketly, every shock you can treat with high flow oxygen, supine, rapid transport, and keeping them warm, right? And then when we get into the more fine stages of shock, then we start to branch off how we treat them. But for the most part, like, you're safe doing those things in any shock. Okay. Tidbits for your tests. Neurogenic shock is the only shock that presents with the low heart rate. Don't forget that one, because that one will come up. Okay. All right, y'all are free from me tonight. Good work.
Thank you.
CJ, are you good?
Yeah, I'm good. You hit stop record?
Charlie boy?
Can you hear me?
No, I think he's trying to talk to you.
I know, hear you.
I hear you. Yeah. Just stop record, Mike.
What are you trying to do?
I was trying to trick you. I'm gonna try you with.
Yeah, for sure.
You're right. Oh, sure.